Hello, everyone. Thank you for tuning in for this episode of Men's Health Unscripted. Today, we have a special guest interview. Joining us from Montreal, please welcome urologist, Dr. Andrew Steinberg. Dr. Steinberg, thank you for taking the time to talk with us today. How are you doing?
My pleasure. I'm doing great. I'm on vacation, so I'm nice and relaxed, so it's perfect timing for this.
Well, thank you for doing this. Thank you so much for taking the time out to do this. We really appreciate it. And we've done a lot of research on you and some of the programs that you do. And we're really excited to do this interview with you.
Great. It's my pleasure.
Yeah, we're hoping to get a lot of information from the urology standpoint, a lot of the valuable information and content you put out. We know that you're very active on social media, so hopefully we can share that message with some men and loved ones that could really use that message. So again,
100%.
Thank you. And we know you're on vacation, so we'll keep it short, simple, and packed with knowledge for all of our viewers.
Absolutely. And I like to talk, and I like to talk about anything for men's health. So don't be shy. Anything is on the table.
We're on your clock, apparently.
That's it.
Well, as a men's health channel, it's important for our viewers to be aware of the different perspective of men's health issues between the two countries, the U.S. and Canada. And in your professional experience, and in what we found that it's much bigger in Canada. So why is the topic of men's health more discussed and confronted in Canada versus somewhere like the United States?
Well, that's a long. I don't know the difference. I mean, it's Canadians and Americans are different for sure. I think we're much more laid back, much more at ease as a whole. I think these issues men are just afraid to talk about. I think that's a major problem on both sides of the border and around the world, really. I think it's, I don't know if it's our culture or our weather, or we're less likely to be, macho guys, and again, I don't know what the answer to that is. I don't even know if that's I think it's changing everywhere. I think people are talking more now than they were 5 years ago, and more than they were 30 years ago. I think the biggest driver everywhere was Viagra, because that brought out erectile dysfunction or sexual dysfunction into
that kind of put it on the map.
That put it on the map, and that's where all these people who put her under the table, because there were not great options at the time. Mm-hmm. There was surgical implants, and there were these injections into the penis, which is very effective, but not something that I see you just cringe just even talking about it. That most people don't want to give themselves a needle to get an erection, and Viagra was safe and effective in many men. So it brought out all these men saying, I can see myself doing that. And maybe I should go seek to my doctor. And that started, I think, the revolution. It also started the more people that we saw. And the more people that we saw who wanted to come from Viagra. And then the more failures, the more advanced cases, it just sort of really put sexual medicine for men, at least. I mean, women still, I think we're way behind, but we're getting there. But it put it on the map.
Sorry, were you in practice during that time? Like when it came out, were you in?
I was a resident. I was a resident, and I remember my first urology textbook when I was a resident. I went back and there was a paragraph about this new medication that's being studied, and looking back on it, I mean, it's amazing that just in my short career, that we came from that to this,
there's definitely been a whole proliferation now. We have the 4 Hims, we have Get Roman, we have Blue Chews, and it's really kind of, and that's just like men's, sexual health function. And
that hasn't taken off in Canada yet. I know there's a couple of companies actually approached me. I don't know for anybody who doesn't know what those are. Those are sort of websites that you basically call in and get to fill out a questionnaire and maybe speak to a doctor for 3 minutes and get a prescription for Viagra. I'm not sure how I feel about it yet. There's definitely some good things and definitely some bad things about it. But I mean, it's a huge industry, and in the States more than here, and it started to lead to all the other issues, because just because you have sexual dysfunction. Everything was lumped in. Okay, I need Viagra. People come to me for that, but they have other sexual problems. They may have a low testosterone. They may have premature ejaculation, but they just lump it in. They get consults from the doctor, erectile dysfunction. And many times it's not. That's some of the problem with those,
Do you see a lot of clients, like if they come in with erectile dysfunction, do they assume that Viagra is their first line of choice and they just assume that's what's going to happen? They don't assess really prostate health, any other conditions or diet?
Yep.
Really? Okay.
100%. And that's a great question. And there's so many things associated with it. As you say, diet, obesity, diabetes, high blood pressure, these are all precursors to it. And more and more studies are showing that also that erectile dysfunction is the canary in the mine for heart disease. So if you're 47 and you have, or 42 and you have erectile dysfunction, real erectile dysfunction, not you got drunk last night and you couldn't get it up because your girlfriend was mad at you. I'm talking about real organic, let's call it erectile dysfunction. You are higher risk for having heart disease. So blood vessels to the heart are analogous to blood vessels to the penis. If one of them is blocked, chances are the other one could be blocked. Yeah. So if I have a guy who has significant heart disease, erectile dysfunction, I actually send them more and more to cardiologists for a workup. So back to your question, we need to know, it's not, Viagra is great, but there's so many other, it's an opportunity to get, first of all, men in the door to talk about other things and say, hey, look, check your cholesterol, check your thing, lose weight, please stop smoking. It's a great, it brings them into the office for sure, but there's so many other things at that point that we can take advantage of.
Would you say that like having the option of Viagra or any of these blue chews have kind of let men put their guard down and talk more about it because they know a solution is so readily available? And like you're saying, it gets you in the office, but it may not be the solution that's warranted.
Well, 100%, for two reasons. One, because it may not be the problem. As I sort of mentioned before, they may have another problem, which they're just calling erectile dysfunction. And a very common one is premature ejaculation. And some of that comes from the patient. Some of it comes from the primary care physician, because I don't know, in the States, it's a little bit different, but in Canada, you're on a conveyor belt, in and out, in and out, in and out. You want to get as many patients as you can. I have done what very few urologists, maybe one other one in Canada, have done, and I've actually gone off the grid. I've gone off the national Medicare program, and I'm private for fee. There's two of us in Canada. So because of that, I can...
In all of Canada?
In all of Canada.
Wow.
And we're both in Montreal. So I can take the time, the way my practice is set up, to spend... I used to see 12 patients an hour. Okay, now I'm seeing 3. So you can imagine I have time to actually speak and know what the problem is. And I've had so many patients come to me. I've seen another urologist, and they say, oh, yeah, I know I lose my erection. Here's a prescription for Viagra. Thank you. I'll see you in a year. Now, they didn't lose their erection. If you ask them more than 2 questions, they ejaculated. So that was a premature ejaculation that they're treating like an erectile dysfunction. Okay, so I see that all the time. Guys with Peyronie's disease, we'll probably talk about that later, with painful erections, and they're not getting erections, not because their circulation is poor, which Viagra is going to help, but because their sex drive is low. And why is their sex drive low? Maybe because their testosterone is low. I've seen, since I've really got interested in the sexual health part of things for men, I can't believe how much testosterone deficiency there is. So these guys, when you question them properly, and it doesn't take an hour questioning to try to get beyond just here's the blue pill, but a lot of them have very different issues and very different solutions than just Viagra. So I think your question is great, and 100% yes.
Do you find yourself diagnosing low testosterone when the male himself is expecting erectile dysfunction as his sole issue?
Yeah, a lot. Probably less so, because I think, in the testosterone community is a little bit weird. I think the patients know more about it than the doctors. So they seek me out because they know that I'm someone who's interested in So that's, with time, I'm sort of seeing a lot of patients coming in saying, I'm sure I've got low testosterone, ABC. And I say, yeah, you should have taught your doctor this because you've been having these symptoms for 5 years. And I look at their blood test from 5 years ago and their testosterone is low. So part of this is misinformation of doctors for the past 100 years. The JAMA, the Journal of American Medical Association, is partly to blame for worsening this. In 2013, they published a study which showed false data and said testosterone replacement therapy is bad for the heart. And if you just, with grade 9, or I don't know what you call it in the States, secondary 3.
Back and forth,
Yeah, statistics. If you just know basic statistics, you can see how wrong. And in fact, in that study, it showed that testosterone is beneficial for the heart disease, as opposed to causing heart disease. So that but once the cat was out of the bag, and CNN and New York Times, testosterone is bad for the heart, and doctors overprescribing it, and doctors are being wooed by the pharmaceutical companies. I mean, the public loves that shit, and that just set back the clocks of testosterone therapy for 20 years. So we're slowly clawing back, and there are tons of people who are suffering needlessly from low testosterone because they're not properly diagnosed, they're not taken seriously, they're put on antidepressants which makes it worse, by the way. If you're feeling down and low, not because you're depressed, but because your testosterone is low, put you on an antidepressant. It's going to kill your sex drive. It's going to kill everything else, So, I'm not against antidepressants in the proper case, but
I think that's really important because you mentioned kind of going off of the Canadian system of the conveyor belt, and so you went from 12 patients an hour to now 3, and it sounds like by doing these assessments, you almost tapped into the real reason as to why you went into medicine in the first place, to actually talk to a patient and uncover what's going on. So that's really cool.
There is never something more. I think one of the most rewarding things is seeing a man properly treated on testosterone after they've been deficient, coming back to the office 3 months later. Just saying, you saved my life, you changed my life. It's really, there's very, I used to do big cancer surgeries, and you save people's lives, and they don't feel sick before, they don't feel sick, they just feel sick afterwards because you sliced them open and took out their kidney. So they don't feel, whatever, you took out my kidney, but they don't feel better. These guys feel better. You saved their marriage. You saved their job. They couldn't get up in the morning. They're tired. And it's a spiral because the more they feel crappy. So it's amazing, and it feels great to be able to diagnose and treat these patients.
Yeah, that's great. That's great.
Yeah,
it makes sense that testosterone replacement therapy would, I guess, just logically probably be good for maybe the heart, because in the research that we've seen in the short time doing this podcast, it shows obviously better mood, more energy to to perform exercise, weight loss. We know that a typical symptom of being testosterone deficient is building up excess body fat. So 100%. All those things combined probably
obesity, cholesterol pathways, insulin pathways. There's even some great studies out of Europe where they took obese men, and some of them were put on testosterone, some of them weren't. They were deficient, but the ones that were put on testosterone, you can see over the years their obesity decreasing, their diabetes improving, and the other ones were flat or increasing, weren't on. So I think we're at the tip of the iceberg. It got bad press. It's a great it just got bad press and was abused. We have the whole bodybuilder, weightlifting culture who are abusing it. They're taking, these guys come to me because they want to be followed, but they're taking 4 times the recommended doses, and they're not low to start off with. So, and I tell patients who sort of are a little bit worried, I'm not taking you from a man to Superman. I'm taking you from a guy who's low in hormones, and I want to make you normal. I think patients understand it that way. And the best example is the thyroid. You're low in a hormone. You're feeling crappy. We give you this hormone to replace it, not, take you through the ceiling, and you feel better again. And it's the same thing with testosterone. It's a vital hormone. in so many different bodily functions, and lacking it causes havoc in so many different bodily functions. It's that simple.
Just to like retrace a little bit and just to kind of get to the pharmaceutical end of it is like to saying Viagra, Blue Chews, any of those medications for erectile dysfunction, they don't actually increase libido. They just allow for more blood flow to the penis to achieve erection and maintain erection. And I think
100%.
there's really a misconception on, oh, if I take this, my sex drive will be higher. And, you know, and then the results. And so it's a great point that you're making about the testosterone actually increases the libido and the drive to
100%.
go along with.
100%. There's 2 points of that, actually. Another point for the Viagra. So from the pharmaceutical point of view is that one, Viagra helps in the mechanism. The end way for erections is nitric oxide. I don't know if you see men who take nitro when they get angina, right? So that relaxes the blood vessels in the heart. So Viagra, Cialis and Levitra, blocks the degradation of nitrous oxide in the penis. So that allows more nitrous oxide to hang around, and it allows the blood vessels to dilate and allow more blood in, which means erections. So that has nothing, zero, zilch, nada, to do with libido. Libido is not getting a hard on. Libido is everything else that goes with it, the excitement, whatever, and that is testosterone mediated, 100%. The other thing is just with the sort of misconception of Viagra is that you take Viagra and you're going to get a hard on, and you're going to get a hard on, because the half life is 6 to 8 hours. You're going to get, am I going to take this and just get a hard on? No, the beauty of it actually is that it works with the natural pathways, as I was talking about, the nitric oxide. So if you're not excited and you're not sending these signals down, which is releasing nitric oxide, Viagra is not going to give you an erection. So if you take it and your girlfriend has a headache and you're stuck watching a football game, I mean, some people get excited during a football game, but if you're not one of them,
fantasy football season, come on.
Exactly. Yeah. So you're not going to get excited. So I think that's important. You're not going to get an erection. You're not going to get aroused by taking a Viagra. You just wasted $12 for whatever.
So a topic I'd like to
walking around.
A topic I'd like to touch on is, so when we talk erectile dysfunction, we loop back to heart health. And for those patients, those men that are on Cialis, any of these pills, these medications, I'm third-year pharmacy student, so I'm gonna defer to the urologist here. But by taking these medications, you're not improving your actual cardiovascular health, correct? You're still...
by taking Viagra, you may be actually. Viagra was studied as a drug for erectile dysfunction, as was some of the other treatments like shockwave therapy, which is something we're using more and more. But Viagra, there may be some benefit. It makes sense that there would be benefit if you would take it on a regular basis. I know there's high doses of Cialis which are used in pulmonary hypertension, I believe, on a daily basis. So I think if we're looking at risk versus benefit, there's more likely, based on the mechanism of action and some suggestive studies, that it actually may be good for the heart.
That's very interesting.
The misconception that it's bad for the heart is sort of ties into what I said before. The nitro, when you take with angina, it increases nitrous oxide, and Viagra increases nitrous oxide. So if you take them both, you have a higher rise in nitrous oxide and your blood pressure drops. So it's really dangerous not to take that and you're going to have a heart attack. Dangerous if you're having angina and you just took a Viagra, and now you're saying, okay, great. You pop a nitro under your tongue, your blood pressure may drop precipitously, and that may be dangerous. So, but that's where the misconception about Viagra being bad for the heart is. It is not.
Well, to our viewers, before we move on, angina is chest pain. If you hear that term going back and forth, just because it's going to be probably said a lot throughout here, angina is chest pain.
Yeah.
All right. So as a professional, and I know you've been doing this for a little bit, and you've gone from seeing a lot of patients to not a lot of patients, but getting a lot more effective results out of the increased time that you've spent with your patients. Have you noticed when patients come to see you that there's some kind of hesitancy, that you're really you really have to draw a lot of information out of them rather than, maybe somebody just shows up and lays it all on the table?
There's definitely both kinds. There's guys that are just want to tell you everything that happened in their last 20 years because they know there's something there that's going to explain all this, that you're just going to be able to, do that and they're going to be better. So you have that extreme. And I try to explain people that, this isn't a one cause and effect. This isn't, it's multifactorial. The treatment is multifactorial, multidisciplinary. It's not like a bladder infection or a sexually transmitted disease that you slept without a condom and now you got it and you take antibiotics for a week and you're cured. So to try to dissect everything that's happened, you get those kind of patients that just want to throw everything at you. And most of that is not necessary to make the diagnosis or make the treatment. And then you have people that you have to pull it out. Some of it's cultural. There's some cultures which are very, private or less outgoing, and are shamed because of this. I have a lot of Eastern Indian patients who, they're newlyweds. They have huge performance anxiety because it was an arranged marriage, and they're in their mid-20s or late 20s, and then they have a bad night, and it just propagates, and the wife will tell the families, and they will be shamed, and so it's there's a lot of cultural issues based on this as well, of how we talk about sex and how we talk about things. So there's definitely both ends of the spectrum in terms of that.
So you talk about the hesitancy with tradition and cultures. What would you like for men, say men who it's not against their tradition or their culture, it's more just their stigma of men's health. What would you like for them to know from your standpoint, from your professional opinion? Should they be hesitant to see a urologist? Should there be any stigma, any barrier there stopping them? And what?
No, I think
what have you found it?
No, I mean, obviously my answer is going to be no, because the chance of me helping you if you don't come into my office is zero, right? There's so many things that we have to offer. There's even natural medications for erectile dysfunction, which I'm not, one of these herbalists who believe I believe in science, but there are some products out there. I don't know if you guys have heard of L-arginine. L-arginine is an amino acid, and L-arginine is the precursor to nitrous oxide. And you can take it, you get these in the supplement stores, and there have been studies, versus placebo, versus Viagra, so on, that it actually helps. So there are so many different things that we can do to help you. These kind of things get worse if you don't help them, because if there whatever organic biological cause there is, it's going to start to work its way up here, which is just going to make everything worse, and it's a vicious cycle. So the quicker you're in, the quicker you sort of say, hey, I got erectile dysfunction or whatever it is, and I'm cool. And it's 30% of 30-year-olds have some degree of erectile dysfunction. 50% of 50-year-olds have erectile dysfunction. So I'm normal. I'm not normal, but this is super common, and I need to get on this, just like if I had any other medical illness. And that's why there's no need to be afraid, because you're just making it worse by doing that. There's
and that's a message that we kind of mold our mission after, is that how many times can we say erectile dysfunction and these urological problems stem to other systems of the body, like cardiovascular system. So we know we hit on a lot. We're going to say erectile dysfunction is a leading precursor to heart disease, but we find it very important to have professionals such as yourself on here and just keep pounding that message. And we think that's the best way to break any sort of stigma, is the more men come together and talk about these issues that are sensitive and
100%.
Supposedly 100%. Sensitive. Yeah.
100%. And I here's a little shameless plug. I started a YouTube video series with my trainer, and we talk about men's health issues, and we called it "Have the Balls to Talk About It." So everyone go to YouTube, and have the balls to talk about it. And
like
because
the description down below.
Yeah. So I mean that's what it is. I mean, these things are treatable. They're important to bring to medical attention. There's other things that can be done. It could be a precursor to heart disease. It can be a lead to try to get you to, to work out and drink less and party less and all these things. I can't say it's strong enough. Just there's no reason not to. I'm not going to come. You're not going to come into my office and I'm going to put your penis on the table and bang it and say, okay, you're done. I mean, I don't know what people are afraid of. And when people come into my office and I see them are shy, I go at them right away. I say, listen, we're here to talk about your penis. You're not at the dentist. This is normal. I'm here for this. Tell me what's happening. Don't hold back. And I think that's partly my personality. And I don't know if every doctor is the same. And I don't think every doctor cares about it the same way, unfortunately. And they may have had patients. Yeah, and patients may have had bad experience. But so, if you're not happy with your doctor's response to bringing it up, go see another doctor.
Yeah.
Bottom line,
I think that was a really one of the reasons that we started this whole show / podcast is that you can watch these videos in the privacy of your own home. You can get professional opinions, sit on the couch, crack a beer, and watch, some valid information coming from professionals so that you can, essentially muster up the courage to go and to really say, you know what, I'm not going to let this stigma defeat me. I'm going to go see my doctor. And then if we pound it into people's heads enough, like this is treatable, this is preventable, you just got to get in front of the ball.
Yeah.
I think a lot of the stigma behind men's health and the whole culture of men's health can change.
Yeah. 100%. It's happening slowly for sure.
Yeah. So we're hoping our more casual, upfront way about it is
amazing. It's amazing because when we started our YouTube series, I sort of looked online to see what's there, but there was a lot of things for women. There's a lot of women talking about their vaginas and their periods and their PMS and all that stuff. But men don't talk. Men don't. So exactly this. We need more forums like this, 100% to get the word out and start making this normal part of conversation, and to speak to our sons about it, and and our daughters about it, and everything.
Yeah, everybody's got, maybe not everybody, but most people we feel like have a man in their life that they care about, and that we want the men in our life to be around their fathers, their uncles, brothers, all of that good stuff. Yeah. And if somebody's watching this show and maybe they have that person in their life they love, they know something's going on, maybe they can show them, hey, these guys are they're bringing professionals on, they're talking about these issues.
Yeah.
It's we don't want to say it's not that bad because everybody's perspective is different, but it's definitely preventable, definitely treatable. And it's just, again, got to get on the forefront of it.
100%.
Yeah. So as we talk about these issues that men should be aware of, they may hear erectile dysfunction, they may hear BPH, but let's get your take on the anatomy of it. Just a quick anatomical overview so people understand what's going on down there. If someone's sitting on the couch with a beer right now, let's give them a fun, casual anatomy lesson. So, what is the importance of prostate, penile health? What does the prostate do? Why should men care about it? Yeah.
So the prostate is sort of the center of the sexual experience, right? So we'll even start further back. So the testicles produce sperm and testosterone. Okay, so when you ejaculate, people think the testicles squeeze, and testicles just produce sperm, which work their way up. You don't ejaculate from the testicles, so they work their way up to the canals with the vas. So you have a vasectomy, you're blocking the sperm coming through the testicles. Okay, and that works its way up to two glands, the prostate and the seminal vesicles. So those two glands, the seminal vesicles are these floppy things that piggyback on top of the prostate. And they're the ones which are ejaculation. So you squeeze with ejaculation, which has the sperm, which is coming from the testicles, and all that liquid and cum that's produced by the prostate seminal vesicles, and that shoots out through the penis. So it is not responsible for erections. It is responsible for ejaculation. So erection is in the penis. Ejaculation is from the testicle, from the prostate and seminal vesicles. Testicles produce the sperm. So actually erections, orgasm, and ejaculation are three separate events. Okay, they actually do there are three separate mechanisms. And you can have one without the other. You can have, someone who has their prostate removed can still have an orgasm, no ejaculation, no liquid coming out. Someone can have no erections for whatever reason, but the way they're stimulated, even with a soft penis, they can have an orgasm. So they're separate events. Obviously, they're all intertwined and related, but they're separate events. And the prostate, the liquid that the prostate secretes, as I said, is ejaculate. It's not just so you can have liquid coming out. It actually nourishes the sperm and carries it, where it's supposed to go. So it's a fertility organ in the end. And the nerves for the erections are coming right on either side of the prostate. So sometimes prostate disease can affect erections. And if you have prostate cancer, your prostate removed or radiation, that can affect erections in a serious way, not because erections come from the prostate, because the nerves, you have the prostate like this, the nerves are really attached right onto it. So when we do surgery to try to take out the prostate, you have to shave and try to spare those nerves.
Wow. Is that something you do in your clinic? You do invasive surgery like that?
No, that's a hospital-based thing.
Is it? Okay.
Yeah. So the just because it all ends up to the penis, ejaculation and urine, there has to be sort of mechanisms to shut off one versus the other. When you ejaculate, so the urine flows right through the middle of the prostate. So when you ejaculate, the bladder neck closes, so the ejaculation goes out and not in, because it could go either way. The prostate grows with time. Every man, the prostate grows. Like with time, you lose your hair, you get whatever, prostate grows. And when it grows enough, we call that BPH, benign prostatic hypertrophy, or benign enlargement, not cancer. It blocks that tube, and that's when men start to have trouble. And that's one of the most common things I see in men over the age of 50, 60 is difficulty to pee. They wake up at nighttime, the pressure's not there anymore when they pee, and that's because of the prostate. Usually,
is that one of the reasons why the residual volume in the bladder is one of the diagnostic tests you'll do? I saw that on your website, right?
Yeah.
Okay.
Yeah. So because if it blocks enough, you're not going to empty your bladder, and that can start to increase the urine left in the bladder. That can get infected because it's just sort of sitting there. It can cause back pressure on the kidneys and damage the kidneys ultimately. So it's something that needs to be followed on. If you, again, like everything in this field, if you find that early, it could be treated easily and no problem. If you let it go, you can end up in dialysis because of kidney failure. So, if someone's having symptoms which aren't normal, and I think you all know what's not normal, if you're waking up 5 times a nighttime to pee, that's not normal. If you're peeing drips, that's not normal. So these things need to be worked on and worked up before it gets to a point where it's too late. And it's easily treatable when it's not too late.
That proactive approach you're talking about now is really one of the first topics we took on for the podcast. We filmed for one night, just like 6 hours straight. We just talked prostate, BPH, prostate cancer. We talked all of that. And we came across questionnaires, whether they're using the clinic or self-questionnaires, the AUAs, BPH.
AUA symptom score. Yeah.
Yes. Do you endorse that for clinical use only, or do you mention that to patients to do on their own?
I mean, either way, if a guy comes into my office, I don't necessarily use it, because I just ask the questions mentally and I mark down he pees 5 times a nighttime, his pressure is low, and he's running to the bathroom. So it's good to follow patients. These are standardized questionnaires. I think they're great tools. And it's good that we're going to put updating my website. We're going to put on the website so patients can sort of check in and say, wow, my score is 15. That's pretty serious symptoms. And so it's a good way of making people aware of the scores. I think the more people can take understanding, and they're going through this and saying, okay, well, this isn't normal. I mean, I should pee once a night, not 5 times a night. So I think they're great if they're out there and get men just thinking about their health. Anyway.
Yeah, that was one of the first things we did. We just put the questionnaires out there in case a man didn't want to go to the clinic, but they found the link and they're like, oh, maybe I should just go take this to a doctor to see.
Yeah.
So
I think that's great.
Yeah, and then if they're uncomfortable discussing the topic, they can hand you the questionnaire and say, here's what's going on. And then you're a professional, you can lead that conversation and get the information that you need out of them.
Yeah, and my new website that's going to launch soon has exactly that. And if you have sexual symptoms, there'll be a sexual score, and then you'll put your name and any complaints that you want to put on, and that'll come to me with the results of your score. I think that's great.
What's that website? Just so we have it, we can put it in the link in the bio.
It's steinbergurology.com.
Okay, perfect. So link in the bio, everybody. When you see this, that'll be another tool available to you in case you need a professional to guide that conversation.
Mm-hmm.
So one thing we haven't really talked about before is prostatitis, and we've kind of.
You have 3 hours?
Excuse me?
You have 3 hours?
Well, we film episodes before the whole COVID pandemic thing kind of started to take charge. We were filming episodes and just having casual conversations. Stephen and I were doing some research, getting clinical guidelines, and providing just information on different situations. We never really got to the prostatitis part. So could you give our viewers maybe a little overview of it? Maybe not the 3 hour version, but the couple minute version.
Yeah, I'll give you the couple minute version.
Differentiate that between that and maybe BPH or something else.
Okay, so very easily, BPH is more urinary symptoms and chronic prostatitis is pain. So there's 3. For easy discussion's sake, there's 3 types. It's acute prostatitis. Okay, if you have pain, difficulty to pee, but you got fever and chills and you feel crappy, you go to the emergency room because that needs to have antibiotics now, or you get sick. Okay, those people feel like shit. Okay, so that's not really difficult to diagnose compared to the other one. But then we have the 2 other main categories, which is chronic prostatitis and chronic pelvic pain syndrome. Okay, we used to think that all this was caused by bacteria, and we put you on Cipro or Septra for 6 weeks, and that didn't work. We put you on another 6 weeks, and it's hard to diagnose because it's not like a urine. You could just pee in a cup and you get the urine sample and you see if there's an infection, but it's hard to culture the prostate. It's a solid organ. I get some guys to ejaculate in a cup and then we send that for a culture, but it's not precise, or you can do a massage, a rough massage of the prostate and collect the liquid. It's impractical and imprecise. So it is hard to diagnose, but really BPH, enlarged prostate, is difficulty to pee. You wake up at nighttime, you're dripping, your pressure is low, you may have to pee often, but you shouldn't have pain. Chronic prostatitis or chronic pelvic pain syndrome is you may have pain just below the belly button. You may have pain in the perineum between the testicles and the anus. You may have pain in the rectum. You have pain in the testicles. Some of the difficulties to pee, you may pee often. Ejaculation may be painful. So it's more generalized pain with the urinary symptoms than just the urinary symptoms alone. If you don't have urinary symptoms, if you don't have pain, you don't have prostatitis. Okay, and again, so it's not difficult to diagnose BPH and prostatitis, but the bacterial ones from the non-bacterial ones. And now it's more and more thought that some of these are caused by pelvic muscle dysfunction. So we're treating them more with physiotherapy, anti-inflammatories, sitz baths, warm baths. We even use Valium suppositories that can relax the pelvic muscles. And we're being much more successful, in my opinion, than we were in the past, in just throwing antibiotics. So, how to diagnose and differentiate between the two is quite difficult, and that's where the 3 hour discussion comes in. But to try to, it's a frustrating thing for patients because you can't diagnose it like you can a pneumonia or a urine infection. You can't just do an X-ray and say, this is prostatitis. Mm-hmm. So what I try to tell patients, and I don't want to take credit for this came from a book called Headache in the Pelvis, which talks about some of these symptoms, is it's like migraines, right? You don't see a migraine, you don't feel a migraine on an exam. You can't do a CAT scan or an X-ray or an ultrasound and say, oh, this is a migraine. It's based on symptoms. So then the guy says, well, how do you know this is or he writes a lousy review on RateMD. Doctor didn't even send me for test. It's based on symptoms. If you tell me that this, and we do some tests to rule out, to maybe have a bladder infection because you have a little bit of burning when you pee, or maybe you got prostate cancer, so I feel your prostate, or send you for a blood test, or whatever it is. But it's based on symptoms, bottom line. And there are many other diseases which are based on illnesses. Just some patients find it hard to accept that. They want to see the paper saying diagnosis, prostatitis, whether it's a blood test or a urine test or something, which doesn't exist for this. Doesn't mean it's any less a disease, and doesn't mean that, it doesn't mean I'm telling you it's in your head, but it is what it is. You can't see a sore back, you can't see a pulled muscle. You diagnose it based on the symptoms and how it happened.
If we're talking infection of the prostate, would patients expect to see blood in the urine, or is that separate entirely?
May or may not. Yeah.
Okay. If we're talking symptoms and you bring up the migraine thing,
the standard prostatitis, chronic prostatitis, chronic pelvic pain, you don't see blood. So that's, if you see blood in the urine, you need to see a doctor now.
Yeah.
This week, next week.
Blood in the urine, see doctor now.
Yeah.
That's the take-home message right there.
Yeah. Blood in the urine. Blood in the sperm, you should get it checked out. Everyone comes in freaking out they have prostate cancer. But blood in the sperm is often nothing. It's often just an inflammation. And again, I like to use analogies that patients will accept, but it's like having a bloody nose. It's a blood vessel that burst in the prostate. You need to make sure there's no prostate cancer, but in 15 years of my practice, I've never diagnosed prostate cancer by someone who's come in with blood in the urine. So.
Okay. Well,
in the sperm.
Blood in the sperm.
Yes. Okay. Blood and ejaculation.
Oh, that'd be terrifying.
Yeah, it is terrifying. People come in freaking out, but usually the vast majority of times we don't find anything.
Well, that's fortunate.
Yep.
Well, we touched a little bit before, but we want to get you to speak your mind. And we think, like we mentioned, people have a misconception that these urological issues arise only when getting older, which can be all the more devastating to a young man's mentality. And one of these conditions that are typically aligned with the aging process, as we mentioned, is that of low testosterone. So what are some of the signs, symptoms of low T, and what can a man do to improve that condition?
Anything sexual, most common would be decreased libido or sex drive. There's erectile dysfunction can be caused by low testosterone alone. But there's all the other symptoms, or less pleasure with ejaculation. But then there's all the other things. There's difficulty to exercise. They don't feel like they have the same stamina. They're tired. They feel like they're in a brain fog. No matter how hard they exercise or diet or work out, can't get rid of the fats around the waist. They can't concentrate at work as much as they can. That's pretty much the main spectrum of it.
Yeah.
There's a good questionnaire, actually. It's called the ADAM, A-D-A-M, androgen deficiency, something or other questionnaire that sort of goes through most of those points. And it's a good, similar to the prostate symptom score. This is a good one for.
Would a patient be able to do that on their own?
Mm-hmm.
Okay, yeah. So we'll put that down in the description down below.
Yeah.
Fantastic. Thank you for mentioning that.
Yeah.
So we want to switch gears a bit here and talk about conditions that people may be less familiar with, because we talked BPH, we talked ED, everyone knows those, but we go on your site, we see a lot more interesting things out there. And so people may know about Peyronie beer, but that word has a different meaning in your profession. So what is Peyronie's disease, and how does a man proceed with that diagnosis?
Peyronie's disease is scar tissue that forms somewhere along the penis, usually on the upper surface, and it's collagen. And because that's scarred, it's often painful in the beginning. And what most people notice first is when the penis expands in erection, this collagen area doesn't expand as well as the rest of the tissue, so it curves the penis. So the four things which should lead you to possible Peyronie's disease is: one, painful erections.
Sure.
Two, you often feel that collagen plaque, and it's a little lump. You sort of feel under the surface,
It's
not
like a nodule.
but
Yeah.
yeah. And it could be small, like the size of a penny, or it could be a couple of an inch long. So there's the nodule, there's the pain, there's curved erections, and sometimes it doesn't look a curved erection, but you may sort of see the erection with an hourglass deformity because it doesn't expand all around. And erectile dysfunction. Some people with erectile dysfunction, Peyronie's disease can cause erectile dysfunction as well.
Wow.
So yeah.
You mentioned scar tissue. Does it result from trauma or?
It's sometimes, I diagnosed a patient today who had a sort of a painful intercourse episode, but often they don't recognize the initial event, and it's believed to what they call micro trauma. So sort of time after time, these little traumas in the two layers of the skin, not the skin, but the corpora, the tissue around the penis, that sort of rub together and causes some irritation that starts to heal with scar tissue. So sometimes there is a definite trauma. More often than not, there's not a seminal event, like that's when it started. Sometimes it just creeps up on you and they don't remember an event.
So now I'm curious, and I'd be surprised if a viewer wasn't curious. If you don't mind, what's the most extreme angle you've seen in this condition?
90 degree, like
get the hell out of here.
Yeah. And treatment depends on how much it bothers them. So I had a guy who had a pretty severe thing and he wanted to fix it, but he's still able, it wasn't painful, and he's still able to have, great sex. So he wanted to go for a surgery, and I actually convinced him out of it. I said, you're doing well with it. I know it looks funny maybe, but your girlfriend was sitting next to him. She's like, doesn't bother me. And it didn't hurt him. And his erections were, rock hard. So,
Wow.
it has to do with, what positions you're doing and how your partner can accept it. And so, yeah, but there are some,
it sounds like you have to adapt.
Yeah.
Wow. That was way more extreme than I thought it was going to be.
Yeah. No,
wow.
That's rare, but normally, you see them in the 30-degree range, 30, 40-degree range.
So the surgery is invasive to go get the scar tissue out, or?
Well, there's treatments without it. There's actually penile traction devices. It looks like a medieval torture thing, but it's actually something that pulls the penis straight, and you wear it for about an hour every night. And over time, that can improve by 20 to 30%. So it sort of pulls the penis straight, and as it heals in a more straight way. I mentioned that plaque was collagen, but we can inject collagenase, which melts the collagenase. It's called Xiaflex. That's something relatively new, and it's a series of 8 injections into that little plaque, and that can improve by 30-40%. And then the easiest type of surgery is if your curve is like that, instead of removing the plaque, which would be on this side, it's to actually put in stitches on the other side, which pulls it straight. So you're sort of counter levering. Problem with that is that when you do that, because it's sort of short on this side, it actually causes a little bit of a shortening of the penis. And then finally, to remove that plaque. But if you have a big plaque here and you remove it, you're left with a little hole in the tissue. So you need to put a graft, and sometimes they take that from the mouth, in the cheek, and or different types of grafts to put on top of that. So that's a more, for more advanced cases.
Is that a case-by-case basis, or do you have a favorite go-to?
No, I don't even do those surgeries. I send them to one of my partners, but I can't even remember. Maybe 1 out of 100 patients ends up needing to have to go for surgery.
Really?
Yeah.
That's really interesting. Stephen, I learned something new every time we do this podcast or interview. Thank you, doctor. That's
my pleasure.
90 degrees. Oh my goodness.
Yeah, I really think we do all this research to get prepared for you guys. Every single time, we learn
blown away.
not to it's awesome hearing all this information.
Yeah.
And you and I are both just, for lack of a better term, huge nerds, and I guess we're men's health nerds.
That's awesome.
But at the same time, the information that you guys give is so important because at some point in time, we'll be out in the field just like you, and we'll be able to help patients.
Yeah.
Super valuable.
This knowledge is important to get out there, 100%.
For sure.
Yeah.
So by the numbers we found, about 2/3 of males are uncircumcised worldwide, which kind of shocked me. And just, it seems so traditional. And according to your clinical practice's website, that is, for lack of a better term, a risk factor for a condition known as phimosis. So what is phimosis?
A risk factor, you can't get phimosis if you don't have a foreskin. So, if you're circumcised, you can never get phimosis. Phimosis is when the foreskin gets
still there,
too tight.
Yeah.
And what happens is either you can't pull it down anymore when you're soft, in a more extreme case, or when you're erect, you get erect and it's just stuck because there's usually a scarred ring at the tip of it. Or you can get it down, but it sort of strangulates a little bit because it gets tight. It's basically scar tissue, and it sometimes causes a vicious cycle because when you get erection, you stretch it out. That tissue is not as stretchy, so it causes these little micro tears, and these micro tears will heal up as scars, and they'll become less elastic, so they'll tear more when you stretch it, which is erection, you stretch it, and it gets worse and worse, and that can make it difficult to clean. And if it's difficult to clean, you can get more likely to get prostate penile cancers and stuff like that. You can even block up from urine. I'm not suggesting that every man gets circumcised to prevent this, but I think if you're having trouble with the foreskin, take care of it. Like many things we've talked about, when I get guys that come in just at the beginning, I often give them this steroid cream, cortisone-based cream, which softens the tissue. And that can prevent men from needing surgery, because if you let it go and it gets too stuck, it's a circumcision.
So you mentioned steroids, and kind of the way you describe what phimosis is it in any sense of the word chronic inflammation at all? Because it sounds like that vicious cycle. Is that what it is?
I mean, you can have phimosis without the inflammation. So and some people are just born with it and never. Almost most kids are born with a difficulty to put down the skin, and it sort of grows with time. But once you start to get that inflammation and healing and scarring, that takes us almost to the next level. And that's called BXO or balanitis, xerotica obliterans. So when you see those ones which is just not much scar tissue, that's more basic phimosis. When it starts to get white scar tissue and it can get white on the tip of the penis, whatever, that's more BXO, or some people call it lichen sclerosis, and that's more the inflammatory cycles, sort of scarring, trauma, inflammatory, scarring, trauma, inflammatory. And, yeah.
Wow.
So steroids can sometimes, when caught early, break the cycle.
So like after all that, do you see circumcision being an option, or is it kind of just?
Yeah, in my office, I do 2 to 3. Myself and my partner is probably 10 adult male circumcisions a week or a month.
Really?
Several a month. Yeah. I'm not talking about some guy whose girlfriend doesn't like his floppy foreskin. I'm talking about for phimosis, for medical problems.
I really feel like it's not an issue that we even hear about too often, or
I've never heard of it.
Talked about.
Yeah.
So the fact that you're doing around 10 a week is pretty crazy.
Yeah.
Wow.
It's not uncommon.
So for the viewers that maybe in that situation, or they're noticing something going on down there, I know you mentioned some aggressive inflammation in that cycle, but what are some of the early indications that something is not right?
Simple difficulty to lower the foreskin, or when they're in erection, there's this kind of ring, like a tightness of the foreskin, and it's usually like whatever, the tissue should be nice and loose, but if there's one area that comes from the top of the foreskin, when it comes down during erection, that causes almost a strangulation. It doesn't have to be so severe, but if you sort of see that indent and it's a little bit irritating, that's phimosis.
Always learning something new. Always learning something new in this podcast.
Yes. And you're just to go back to the steroids, you guys are in pharmacy, you know, we tell patients don't use cortisone cream too much because it can thin out the skin. But that's exactly what we want. We sort of use the side effect of it as the beneficial effect.
That's interesting.
We want the skin to thin out so it's more loose and paper thin and stretchy.
Yeah, that's
fantastic. That's fascinating.
Yeah.
Like, we're talking about foreskin. I find that fascinating that medicine, the way that you're using medicine in your office, just to handle these problems that some men don't even know about. I mean, that's really great work you're doing. And Dr. Steinberg, we really appreciate you taking the time to share, you know, this plethora of knowledge. And we look forward to having you back on, maybe for that 3-hour explanation of prostatitis. You know, a lot of these topics can be very overwhelming and intimidating for a man to confront.
Yeah.
But with healthcare professionals like yourself, there's no doubt that the future of men's health is heading in the right direction. So everyone check out Dr. Steinberg's information in the links down below for quality content. His website is steinbergurology.com and Instagram @SteinbergUrology. Please subscribe to our Men's Health Unscripted channel, like the video, comment down below, follow us on Instagram @Men's Health Unscripted and Twitter @unscripted_MH. Dr. Steinberg, thank you for being with us, and we hope to have you on again, like we said, in the future.
Anytime, give me a call.
Absolutely.
It's been a pleasure, guys.